Hello, I'm Andrew Thompson. I'm a Professor of Clinical Psychology based at Cardiff University and Cardiff and Vale University Health Board, and I'm going to be talking to you about our study that examines the mental health burden associated with alopecia areata. Alopecia is a chronic inflammatory disease affecting hair follicles with a peak incidence in early adulthood, and there are relatively few studies that have looked at the psychological impact. And what we wanted to do was to determine whether adults with alopecia areata are more likely to develop mental health conditions than matched controls in the first 2 years after diagnosis. And we also wanted to have a look at whether there was any impact on work in terms of time taken off work and periods of unemployment. And finally, we also wanted to look at the treatment pathways for those experiencing anxiety and depression in comparison to matched controls also experiencing anxiety and depression. So in order to achieve our objectives, we extracted information from the Oxford Royal College of General Practitioners Research and Surveillance Centre database. And this is a database that contains general practitioner records of over 4 million people living in England. And we extracted data from people with alopecia areata based on diagnostic codes, and these were matched to 4 controls drawn from the same GP practice. We then used Cox proportional hazard models to identify the associations between alopecia areata and our outcomes of interest, and we adjusted for a number of confounding variables. We looked at 5,435 new cases of alopecia areata during the study period, and these were matched with 21,740 controls, and the mean age of the individuals within our cohort was 39 years of age, and over half of them were women. Common mental health conditions were more prevalent in people with alopecia areata at diagnosis in comparison to the matched controls, and the chart shows that the prevalence of recurrent depressive disorder at diagnosis was just over 12% compared to matched controls at just over 8.5%, and the prevalence of depression episodes in people with alopecia at diagnosis was just under 19.5% compared to matched controls at nearly 15%. And again, the prevalence of anxiety disorders in people with alopecia at diagnosis was just over 16.5% compared to matched controls at just below 13%. And we saw similar patterns regardless of the socio-demographic groups that people fell into. In the 2 years after diagnosis, 3.5% of people with alopecia were diagnosed with new episodes of recurrent depressive disorder, and just over 3% were diagnosed with a new episode of depression, and just over 3.5% were also diagnosed with anxiety. So in people with alopecia areata, we did find higher rates of time off work as demonstrated by the use of sick certificates, and also we found that there were higher levels of unemployment in the year after diagnosis. In terms of healthcare utilisation, alopecia was associated with the same level of prescribing of anxiolytic medications when compared with controls with the same sort of mental health conditions. However, prescriptions for antidepressant medications and referrals on for psychological therapy were higher amongst the people with alopecia. So in summary, our study demonstrates that people with alopecia have a higher burden of anxiety and depression, higher rates of time off work, and are more likely to be unemployed. If they have anxiety and depression, people with AA are more likely to be prescribed antidepressants and to be referred to psychological therapy. So clearly the take-home message here is that clinicians need to be screening early on in the course of the disease for comorbid psychological distress and putting in place the appropriate support.